SMCI Improvement Publication Award submissions currently in progress. Please submit any improvement adjacent manuscript you have for consideration in the award. I will put the Smartsheet link in the chat right now. But please submit your manuscripts that were published in the previous fiscal year. Also, I would love your help judging the abstracts and manuscripts. I am looking for judges to judge either abstracts and manuscripts. It would be 8 to 10 abstracts or 3 to 5 manuscripts if we have enough judges. Please send me an email if you are interested. And this is a great opportunity for trainees who might be interested in improvement work and publication to get a good feeling of like what is Stanford publishing and what makes a good manuscript and abstract. My email's in the chat. Third announcement is we have the Lily and Donnelly SC grant in the pediatric space. It is due, applications are due January 22nd, 2024. And this is directed at maternal and child improvement efforts. There's more information on the SMCI website, so go check it out. It's a great opportunity to get some funding for improvement operational work and evaluation for your ongoing projects. And then to the main part of today's meeting, I want to introduce Dr. Manali Patel. She is associate professor at Stanford University in the Division of Oncology and affiliate faculty of the Department of Health Policy at Stanford University, and also staff oncologist at the VA in Palo Alto. She is a health services researcher and directs the research program that focuses on improving equitable delivery of value-based cancer care. She uses principles of community-based participatory research in her work and is principal investigator on multiple externally funded awards. Dr. Patel also serves on several national committees focused on improving cancer care delivery and value-based care, and has served as the chair of the American Society of Clinical Oncology Health Equity Committee and the ACSO Underserved Task Force. She earned her medical degree and master's in public health at University of North Carolina, Chapel Hill, and followed with an internal medicine residency with hematology and oncology fellowship, and master's in health services research at Stanford. And Dr. Patel was actually one of the recipients of the best improvement publication in adult population last year, so our third annual improvement award publication, and we were so excited about her work. We invited her to speak today on that awesome work she did last fiscal year, and maybe some updates also in her presentation today. But thank you, Dr. Patel, for being here today, and thank you all for joining us. I'll pass it on to you.
Of course, thank you so much. I'm really excited to present our work. I'm going to share my screen now and talk a little bit about the formative work that led up to this project and the paper, and then also talk about what we're doing currently as next steps. My screen just went black, so I think it's probably going to load. There we go. And so the title of the talk is a little bit different than what you may have received in the flyer regarding this presentation. It's mostly because I'm going to present a bigger picture of what we've done and hopefully what others can take away and incorporate some methods into their own work. So I'll give a brief background, talk a little bit about multi-level stakeholder engaged research as it relates to oncology, and then give a few examples of supportive cancer care, including the paper that won the amazing award last year. Thank you so much. And then finally end with the why, given all the misaligned financial incentives that I'll describe. So unfortunately, As many of you know, I think every year when open enrollment comes around, I get a little bit nervous because the premiums continue to rise and the out-of-pocket costs continue to rise. Yet, especially in cancer care,
Manali, you're not in presentation mode if you wanted to.
Oh, let's see. Use slideshow. There we go. How is that?
Perfect.
Okay, perfect. Now I can't really see all the slides. Looks like it's one of them. Anyway. All right. So it looks like, unfortunately, the costs of cancer care are rising significantly. And this is not leading to any better care. So you would expect that if you pay more money, you're probably getting a better product. And unfortunately, the more we dump into cancer care, and I think healthcare in general, unfortunately, the worse care seems to be getting. We see that, unfortunately, many of our patients, many of you who are in the hospital know that our patients with oncology and with cancer are really unaware of their treatment goals, prognosis. Unfortunately, this number has not moved much despite decades of research, even with our team, indicating that advanced care planning is pretty minimal at best. We see many patients with undertreated symptoms. Stanford's buying up tons of practices all over the place. And unfortunately, what this does is kind of shift care into hospital settings that then leads to a rise in costs as well.
Go ahead.
We see a shortage of professional teams. So we have very limited palliative care access. We have very limited oncology care access in rural areas, largely due to the shifting care to hospital conglomerates. And then unfortunately, what we see are consistent and rising disparities, especially with every clinical advance that we make at Stanford. There's an inadvertent and unexpected, or rather now expected, increase in disparities due to individuals not having access nor ability to pay. For cancer care, what we see is that there's this big U-shaped curve in costs. And so you have a rise in costs really at the beginning when there's a flurry of activity around diagnosis and there's the initial treatment. And then as patients either die or when patients go into surveillance care, we see that the costs kind of level out. But then you see this other sharp uptake of rise in costs at the end of life. And so our team decided we really wanted to try to achieve the impossible. This was back in 2011, I believe, when Arnie Milstein first came to Stanford, and he joined his band of rebels to begin to think that we could actually improve not only health, but perhaps we could create some innovations in cancer care that could improve care and also lower costs. And so at the time, I thought that this was realistic, and I'll kind of explain why I may be a little bit more jaded, although still on the realistic band, but also thinking maybe this might be a bit idealistic. So I received a wonderful degree at the University of North Carolina, as was mentioned earlier. I became a little bit jaded, as many of you know. I think those I did residency with here, really interested in social determinants of health, and tried to lead an effort as a resident here. And kind of was told, well, it's not really that important. But now there's a little swing back, I think, into understanding that social determinants of health are extremely important. And I really appreciate the paradigm shift of people now actually teaching residents and more residents interested in equity. So I took a year off in medical school and obtained my master's in public health. And I'm not sure how many of you, or if you all know about community-based participatory research and what that means, but essentially it's including individuals in the design of any sort of research effort. And so it really means that when we go into communities, we're not bringing our own agenda to the communities, we're not bringing our own research ideas to the community, but rather listening to the community and taking away what their overall agenda and what they need to address. And so this is an example of, as a budding internist, I was really interested in diabetes management, chronic disease management. And instead, by listening to the community, heard that cervical cancer was a big problem in these communities. And back then, the linkage between HPV and cervical cancer had not been made. Yet we shifted gears. I found two budding OB-GYN folks that were also doing an MPH. We went to the community and we created a pathway for individuals to not only screen one another, we trained individuals in the community to do pap smears, but then we also had to think about the financial implications. And it was a very early start for me in terms of thinking about kind of the finances that tend to run not only health, but also healthcare, and thinking about that pathway incorporated and needed an incorporation of who's going to continue to sustain this program and how are pap smears going to be evaluated and what will we do for any sort of positive finding in terms of the number needed to screen and the number needed to treat. And so we created this really amazing collaboration with the local Planned Parenthood Foundation. And now 20 years later, the program is teaching UNC medical students how to do pap smears. So it's a really nice example of when you listen to the community, you can not only reduce mortality and early morbidity in communities, but then you can also create a sustainable program because it's meaningful and needed by the communities themselves. So I came to Stanford really, as I mentioned, really excited about doing health equity work, and unfortunately got detracted because there wasn't really much going on either in residency or even in fellowship here. And so I jumped ship after fellowship in oncology and joined Arnie when he first came to Stanford and really delved into looking at healthcare redesign. And basically what the design school does at Stanford, which I think is really amazing, is it's kind of like CBPR methods with a Silicon Valley twist. So it's kind of on steroids. And it was designed really to create products. So for example, the iPhone, if you create an iPhone or if you create a product that is going to generate revenue, you really need to think about who the end users of that product will be in order to be able to generate that revenue. And it's very, very similar to CBPR, but there's also what was missing in CBPR is that clear linkage of the financial pathway that is extremely important when you think about redesign. I think in healthcare, as we'll talk about a little bit later, the alignment not only of goals, but also payment models is really necessary to achieve that idealistic or realistic triple aim. And it requires thinking about not only the interventions you're going to create, but also how you're going to sustain the intervention at each of these levels. So what is going to be the end cost for the patient? What's going to be the end benefit? And then going through kind of a mental exercise at each of these levels to figure out how to design an adequate program that will ultimately be sustained, but then hopefully be incorporated in policy. And so we started off, the paper that we received the award from is kind of smack dab in the middle, but I'm going to start by describing what we've done to try to begin the work, and then give an example of what we did in the VA, what we've done in a Medicare Advantage organization, and how that led to the paper, and then kind of skip over the 5-level example and then go directly to what we're doing now. So we started off with CBPR, so again, community-based participatory research and redesign, and really thought about all the stakeholders that we needed to include if we were thinking about how to not only improve care, but reduce costs. And so the 2 areas that we were focused on were that peri-diagnosis, so the first part of the U-shaped curve, and then the end of life curves. But there was a higher yield if you think about care. And for me personally, what was driving me to go into oncology was really this goals of care and advanced care planning. It seems like a no-brainer that you would want individuals to have better prognosis understanding and to have better symptom management, especially at the end of life. And perhaps you can begin to change payment models, because this just seems kind of common sense that we should be paying for better care at the end of life. So we included not only patients and caregivers, but a critical component of this was payer organizations. Now, what I thought was going to be easy was actually really hard. I thought it was kind of like I mentioned, a no-brainer that people would pay for this, that the organizations would all kind of get together. But this was before the Affordable Care Act. And so what we heard from payer organizations was that there's no way that they're going to pay for, and we probably shopped an idea out and got tons of perspectives across the United States over a 2-year period. And what we heard from payer organizations back then was that if they were to pay for advanced care planning, they would be considered a death panel. Thanks to Sarah Palin, there was this consideration that payment by insurance companies for anything that may be at the end of life would be considered a death panel. And so it was really hard to get the payer organizations on board. The providers, there was a lot of challenges from the providers in terms of time, capacity, training, who should own these conversations. And back at that point, a lot of cancer care providers really were kind of at odds at palliative care, and there wasn't clear integration nor a conversation even about palliative care being integrated so early on. Whereas from patients and caregivers, what we were hearing was that they would rather have these conversations about their goals, their preferences, and their values, and were actually having these conversations with other patients in the waiting room. They had better conversations with other people that were like them than they did with their clinical teams. And so it led us to kind of map. So I really love these mapping, where you map the domains, you map the barriers on top, and then we map the recommendations. And what we found ultimately was that when you map out the barriers, you map out the recommendations, there was a clear just financial and overall goal misalignment of what these individual stakeholders who would need to come together to create an intervention for advanced care planning. This is why we've been stuck in this no advanced care planning limbo for many years. And so could we perhaps create alignment across at least some of these levels to begin to make change? And so we created, again, with all of these organizations, including the payer organizations, an intervention, like a pie in the sky, idealistic intervention that we could implement and perhaps get some funding, perhaps through a shared savings model, and have people all come together to do a pilot test. And the ultimate model involved community health workers, which is kind of ironic. I had no idea, doing that master's in public health degree, that years later we would be considering lay health workers. But again, from the voices of patients, people like them were more trusted entities. They had better conversations, felt more activated. In addition, which has not now is very important, but at the time there was not really a lot of attention to, was this idea of not waiting for patients to call the hospital when they have symptoms, but rather actually proactively contacting patients and proactively assessing symptoms. Now, there's been a lot of really amazing work by Ethan Bosch and others in the cancer space looking at electronic patient-reported outcomes, but really this proactive assessing patients over time. And so as part of this, we considered, with hospice, they create these medication bundles, which I love, that patients can actually get these medication bundles, and in the bundles are an extra vial of morphine. There's an extra, whatever medications they may need, they have, especially as they're nearing the end of life. So perhaps we could build in kind of a medication bundle, or at least some immediate early treatment. And now the last piece, I kind of got laughed out of being able to do this, but now, 15 years later, people are actually starting to do this, especially in the VA, is divorcing chemotherapy and treatments and bringing them to patients in their homes. It's kind of funny, right, that leveraging telemedicine would be considered innovative and could potentially be controversial, but it really was back then. This was definitely long before COVID times. There was not a payment model, and still we have issues with payment model for leveraging telemedicine. And certainly all the ASP, so the average sales price for chemotherapy, and an additional tacked on facility cost for chemotherapy that hospitals like Stanford really generate revenue for, would not be achievable if those treatments were taken out of the walls of Stanford. And so there was a real pushback by a lot of health systems, including our own, to be honest, about divorcing the chemotherapy from the walls of the cancer center and what that may do in terms of the revenue generation for chemotherapeutics. But it's something that we've continued to push. As you can imagine, a lot of patients would rather have this. In Australia and New Zealand, they provide chemotherapy on a mobile van to get them out to rural areas. The VA has been doing this now for decades, where they've been leveraging telemedicine in Nebraska and providing chemotherapy closer to home in these community-based oncology units. And so we use this framework because now we needed to develop an intervention and actually think about how that intervention was going to improve goal concordant care and symptom reduction. And this was kind of our theoretical model of looking at these multi-level interventions and what we assume we would need to do in terms of changing the health policy environment, changing the built environment, meaning providing individuals with additional access at home if they need by broadband, thinking about community capacity and engagement, and then really beginning, we hope, to have the inputs to improve goal concordant care receipt. So the only place that allowed me to do this, again, I was a saleswoman for many years trying to get centers to do this. Great idea. But because of the financial misalignment was really it was rejected. And this was before the ACA. So a lot of payers were not really interested, as I mentioned. And the one place where it seemed to align was the VA. And I was a fellow at the time. Steve Ash was my mentor. I took another fellowship off and was really working with Doug Owens and other amazing faculty at the VA. And it seemed to be the right alignment. And immediately the VA said, if you apply for this grant and get it, we'll let you do whatever you want, which, you know, for most of us working in the VA, we had thought the VA was not that innovative. There's lots of red tape. It's really hard to even get medications ordered. The electronic health record is really clunky. But yet when you look at what the VA does, it is an amazing place. They have so many innovations, and they ate this model up and said, we are willing to do it. And if it shows effectiveness, we will do it at scale. And here's an amazing funding opportunity that you can apply for. Luckily, we got the funds. We were able to pay for a lay health worker. This was on a 7-minute clip with Al Jazeera America. They came to the VA, took an amazing video of our lay health worker. And we did these segmented discussions. So the first segment of the structured discussion with the lay health worker was about what is an advanced care planning, what information do you need for symptom management, and then segment 2, so additional conversations with the patient after they're diagnosed, or kind of these tailored messages. We actually started the segment 1 before patients even had their first oncology visit. So in the VA, we can see when patients are referred, and we're able to kind of intervene right before patients are able to see their first oncologist and begin a lot of relationship building and legwork. And then finally, creating and helping patients to have that personalized support to complete their advanced directives, to find a surrogate decision maker. Many veterans lack social support. And so unlike Stanford, a lot of our veterans were coming in alone, which at Stanford is usually, at the time, was unusual to see patients come in alone without a caregiver. And so they needed a lot of personalized support. And I think what this led to was a lot of social support that may have led to the outcomes that I'm going to describe. And so this is a clip, which I'm not going to play, but if anybody's interested, happy to show it to you later. This was our study schema. So we randomized patients with advanced stages of cancer into this lay health worker intervention. It was a simple intervention, but we needed to train the lay health worker really well. So they worked with BJ Periocoil. They worked with our amazing palliative care and hospice team at the VA. They received weekly coaching by me, where we would go through cases and we would discuss cases and how to begin to engage patients if there were some difficulty or challenges. I'll tell you, the number one challenge was getting the advanced directives that we had gotten signed out of the drawer from the clerk's desk and scanned into the chart. So that was that we didn't anticipate that barrier, but we were able to get so many advanced directives completed, and I'll show you in a moment. And then our outcome was something simple of like goals of care documentation with the oncology provider. Are we able to move that? And then looking at patient satisfaction, but then also seeing the impact on cost. So we randomized we assessed 800 patients, again, because we were using the electronic health record. Many of these, we did not know if they had a cancer diagnosis. We just knew that they had an appointment with an oncologist, and ended up randomizing about 213 who met eligibility criteria. And you can see here, by the end of the 15-month study period, we had very limited withdrawals from the study, which is, again, just kudos to the VA population. A lot of folks say that veterans don't participate in trials. It's mostly because we don't have trials at the VA in oncology. And when we do, a lot of veterans really stick with it, and there's limited attrition. Ultimately, we had 108 in the control group, 105 in the intervention. And I was just shocked by this, that we found at both 6 and 15 months, a significant improvement in goals of care, as you can see here. So we looked at advanced care planning, which was a combination of goals of care documentation by the oncologist. So the primary oncologist had to put in a note that was stated goals of care, and then advanced directives that were documented in the chart. And as I mentioned, it was really hard to get those documented, signed, witnessed copies out of the desk drawer and into the CPRS. We found significant improvements in satisfaction. And so unfortunately, what we see is as patients are going through cancer care, their satisfaction declines, I think largely due to it's very difficult to reach oncology providers there at the time. We didn't have really a great system for electronic health portal records and et cetera. And so it was really hard. They kind of would call the VA and it goes to a black hole. And that happened to me today. I'm trying to call the front desk and I get in some loop for 10 minutes and then I eventually hang up and call again. And so we see this kind of steady decline in satisfaction over time, which is not unexpected. But what we saw in the intervention actually was satisfaction went up. And I think the community health worker, lay health worker was helping with other aspects of navigating care. Now, I'm presenting this week at our ASCO Quality Symposium. At the time, we saw no difference. This was up to 12 months in survival. But now, about 10 years later, we did another analysis, which was under review and was selected for presentation this weekend, where we found a 25% reduction in risk of death. And so while patients may not have received a benefit from survival if they were going to die from cancer in that first year, what we're seeing, at least from this new data, is that patients may be utilizing skills that the lay health worker helped them with for the 6-month intervention later on in parts of their medical care and may have made them more engaged in their care. And that's pretty consistent with the qualitative study we did right after this. Right after we did this result of this analysis, we did a qualitative study and found that a lot of patients that were still alive at that point were indicating that they had more activation and more engagement in their care, and perhaps that lasted. What we see was, again, really shocking was that there was better care. So now many of you at the VA may know that we are able to provide hospice concurrently, but we still do a really horrible job as oncologists just because we're trained in oncology. There's kind of this view that if you start to even begin to think about hospice or bring up hospice, that perhaps you're giving up, even in a system where we can provide concurrent hospice care. So I actually think that the fact that we aren't reaching 100% is really just a travesty, especially for advanced patients. However, at least for the intervention, we found that the ED visits, hospitalization rates, and hospice utilization was just significantly better for those that were in the intervention. And what this translated to, the costs are low because, again, this is the VA. We looked at both VA and non-VA costs, and there was significant reduction in the end-of-life costs, but then also for total costs of care, the distribution, as you can see in this on the right-hand side, was that variation in cost was significantly lower. So what's happening is that not only are we reducing costs, but we're reducing these outliers, perhaps reducing additional hospital visits. We then, because we couldn't get any group to do the symptom piece at the same time, we had to do this particular part of the model, the symptom assessment piece, in a Medicare Advantage organization, the one that Obama had touted. I'm not sure if any of you know, but Care More Health was touted by Obama as a very forward-thinking Medicare Advantage organization that just really provided excellent care. They've got intensivists, which are kind of similar to hospitalists, even within the plan, the insurance plan. And there are a lot of services that you can receive through the insurance plan, such as clinics and podiatry visits, et cetera. So it's just a really innovative model. They were bought on 100%, but the oncology practice was not. And so the oncology practice said, no way, we're not doing advanced care planning. No thanks, we don't do that. We will do the symptom piece. And in exchange, what we want is a per member per month payment. We also want to have full market share. So we want every single patient that has this insurance in our local area to come to our practice. We're going to do this. And then we also want the payer to pay for the community health worker and a proportion of time for the nurse practitioner. And CareMore did it. And so then I said, well, if we're going to do this, we'll do the evaluation. You agree to do the study. You will have to provide us with a chart review because STAGE is not available in claims data. And so you'll have to provide us with all the data that we need. In addition, if there is any savings, we're going to split it 3 ways. So the patient will get a third, the clinician will get a third, clinician practice will get a third, and then the insurance company will get a third. So all the acute care use that we're reducing doesn't just go back into the insurance company's pockets. It actually will go back to the clinician's pockets. And somehow they agreed. I don't know why. I guess I must be a good salesperson. And so they agreed. I don't think anyone thought that it would be beneficial, but it was. And so what we found was, again, this was a cohort study. So we did a matched control cohort compared to the year prior. We had to do this as part of usual care. It's really hard to randomize individuals in community practices, especially those practices that aren't used to doing a lot of trials. And so what we found was that the intervention group had decreased scores in their symptom burden. So ESAS is on a scale of 0 to 10. Each score, there's 10 different questions, including like an other question. And what we found was that the mean score for all of those symptoms really reduced over time, which you can imagine. If someone's calling you weekly and there's a protocol where then they refer you to the nurse practitioner to intervene over 12 months, that your symptoms hopefully will decline. In addition, we found that anxiety and depression declined as well. We found no difference in survival, but we did find a difference in acute care use. And then this also translated to reductions in costs. So again, we did achieve the triple aim. This is more data at the end of life where we found, again, very consistent results with the advanced care planning intervention. And this has been replicated by others. And then again, for the total cost of care at the end of life, we found that distribution decreasing. So I think it's really this reducing revisits and readmissions to the hospital. And so now the paper that you all awarded was combining both of these approaches. And so we did this with St. Joseph's Health down in Fullerton, California. They were really interested in a randomized trial because they have a really robust palliative care group. So they agreed, look, you have the data from the VA, you've got early data from CareMore. Let's combine this. We're really excited to do this. We actually don't think it's going to make a difference because we do really well with palliative care. And so it was really, we all had clinical equipoise. We really limited it to individuals that we thought would have a high risk of dying within the year. And so it was individuals with more advanced stages of cancer and recurrent cancers. And they were randomized to either the control or this combined intervention. And we looked at patient-reported satisfaction with cancer care, but our primary outcome was really this ridiculous outcome that I didn't think we would meet, which was healthcare use. We assessed 410 for eligibility, 128 were ultimately randomized, and all were included in the intent to treat analysis. We actually had no withdrawals. We did have one death, unfortunately, before the study start, which we anticipate with individuals that are have advanced disease. The majority of individuals in the intervention were pretty matched in terms of their sex. We had a younger age as compared to in our VA study. And there was a high proportion of white and Asian Pacific Islander populations, just given the community. Most had our top 4 cancers, so GI cancers, colon cancer, breast cancer, lung cancer, and prostate cancer. And the most of the individuals had stage 4 disease, with a pretty high proportion of individuals who had a recurrent cancer, so cancers that had been treated and then came back. What we found, again, no difference in survival at 12 months, but we found reductions, again, in the control group, slight reduction in satisfaction with cancer care, but then for the intervention group, a slight increase, and that difference over time. So the difference between the control group and the difference between the intervention group over time, meaning from baseline to 9 months, was statistically significant, even though the satisfaction with care is kind of always kind of capped out. What we also found was that there was significant improvements in goals of care documentation by the oncologist. So while they use palliative care really well, the documentation is not always there. And so this intervention helped patients to actually document their goal, or have the oncologist actually document the conversations in the electronic health record. And we found, surprisingly, a very significant reduction in again, emergency department use and hospital use. And so this kind of translated to a 66% reduction, and not really a difference in palliative care. So these rates are actually really high compared to the general population. I think I see Mohana on here. I mean, I was astounded to see that 77% in the control group have palliative care consultation. It was pretty amazing. So while we were able to move it, it's really hard to move a bar that's already that high. And we saw similar results at Palo Alto Medical Foundation. So we've done a similar study and are launching it across Sutter with Dick Levy, providing foundational funding for most of that. And we found similar results where they really integrate palliative care in a way that's just astounding. Let's see. So the limitations and strengths, you can read the paper, are that it was single institution. Here, what I really need and want to collect are socioeconomic status and insurance type and other demographics to understand how the intervention may impact certain populations. And we were unable to collect healthcare costs. We had no claims data. We could probably backtrack some of the healthcare costs, but it's really hard without having validated claims data. What I thought was really exciting about this was we adapted the project from what we had done previously. We collaborated with a really amazing community oncology practice. It was quite diverse. And in this particular study, it wasn't just one or two community health workers. We actually had multiple community health workers. So we trained and cross-trained multiple community health workers, and all the providers were bought into this study because it was a randomized trial. I'm not going to talk about this study, but this was that level 5 where we've already, we work with a labor union organization that provides healthcare benefits to individuals who are hourly low-wage workers, mostly in casinos, in restaurants, and in other hotels, for example, service industry. And here we included a real focus on addressing health-related social needs. So you can see our community advisory board in the middle. And what they indicated was that there's no way our patients or our members are going to talk about advanced care planning when they can't even get food on the table. And so we're not, you can't even start the intervention until you can address the main health-related and very fundamental foundational living needs. And so we've now demonstrated in a randomized trial the impact for this intervention. It's now being scaled across this labor union organization. And so now across all of these organizations, we found very consistent, robust findings on various outcomes. And with an annual cost savings, again, who's saving the money? It's usually the insurance company. And so really thinking about how to bring some of that funding back is what we've always incorporated, is there's always a shared savings model. And because there's a cost savings for the health insurance company, they are usually the ones that are supposed to be paying for the intervention. And thanks to the ACA, we've been able to really get the insurance companies on board. You know, I'm not as idealistic as I was. I think this has been really challenging. It's been 15 years of doing this, and we're still not really making a ton of progress nationally. But the question now is it scalable? So PCORI has funded, we're in year 2.5 of this 5-year project, a $7 million award that's looking at 24 clinics. And unfortunately, Stanford did not want to participate, which is really unfortunate. So we have Sutter organizations, we've got Kaiser, we have VA, we've got tons of community-based organizations, including we have UCSF, 4 other academic centers, including City of Hope. And we're randomizing individual clinics into either receiving the lay health worker intervention or receiving information that the lay health worker is providing through the electronic health record to patients. Many patients that don't have the electronic health record, we find it unethical to ask them to try to utilize technology-based, and so we're actually mailing it. So we're kind of cheating a bit on the control arm, but that's fine because, you know, if there is a benefit, I would like to be able to see that there's a real benefit. I think mailing out information, the control group will be fine. Our main goal here is quality of life. That again was the community advisory board's recommendation. And then we're looking at a series of secondary outcomes. And so these are the sites that we have currently. We've just added 2 additional community practices. It's just been really a really fun project, a lot of work with 26 different subcontracts. So the Office of Sponsored Research hates me right now, but it has been really fun. And now the VA, we have launched a big program through the National VA Oncology Office on the symptom piece. And so they are taking this on as part of usual care, which is really exciting. You know, I think why I remain kind of less than idealistic is because this financial misalignment. And now we're seeing that hospices are profiting. And so it just is, I think it's hard for me, you know, Don Berwick, who made that wonderful article in 2008 about the triple aim and all this idealism, then just this past year wrote a viewpoint that I really hope all of you read about the existential threat of greed in the US healthcare system. It's really hard for me as a clinician to see that places profit so much off of people when they're at their most vulnerable state. You know, it's just doesn't really sit well with me. And then I see our own clinicians and how demoralized we are, right? By seeing that in a lot of ways, we're kind of this cog of generation of money. And it's just kind of hard, right? And so I think that this kind of poem here, our health systems run amok, folks just out to make a buck, really kind of rings loudly and truly for me when I take myself out of this wonderful VA system that I work in and I do research outside of the VA. It's really this kind of end game of the buck that kind of drives decision making a lot of times. And now to see it even within the hospices and palliative care groups is, concerning. So why do we continue to do this? Why do I have two labs, one at the VA and one at Stanford? And why do we continue to push forward this work is because I ultimately think that we are coming back to this notion that health is really a fundamental right. And it's not going to be this running amok. At some point, the system is going to break. And I think we're pretty close. COVID kind of came close to showing us that we have a really unfortunate healthcare system that kind of caters to the haves and unfortunately leaves those that are the have-nots behind. And we start to see that more of our unfortunate, clinician workforce are leaving in drones out of this healthcare system that we've unfortunately succumbed to. But I do believe that all of us that have gone into medicine and all of us probably that are on this conversation and all of the individuals that continue to go into medicine really do believe this fundamental notion that Paul Farmer kind of instilled in many of us, that health is really this fundamental right, and we need to do everything possible to try to expand health as much as we can. And so we work a lot with practice and policy. So it's so exciting. So remember the community organization that said, no way, we're not doing advanced care planning. Now they're actually highlighting end-of-life counseling on their website as a critical service that they offer. And so while it's not these amazing, it's only going to impact their patient population, it still gives my team the gestalt to continue this work because we're seeing slow changes to what really is demonstrating that healthcare is a fundamental right. We have, again, like I mentioned, that labor union organization. Now they're scaling the program across all their members in the United States. And then it's wonderful to live in California where we've been advocating for policy. We're kind of at the governor's office knocking on the door. And last year to get the reimbursement for community health workers has been a huge change in terms of being able to sustain a lot of these programs. And now having people come in, not having to think about where the funding is going to be for these lay health workers, but now we've got a mechanism to actually pay and it's state mandated is really kind of cool and kind of gives us a lot of excitement. And again, because it's for all of us, I think, and I am idealistic, but I do think people over profit, and we all believe that. And so we've got lots of projects in Monterey County. We have grant funding now with lots of mentees who are getting and doing this work. It really helps to see that if we continue to kind of maintain this idealism in a swarm of unrealistic expectations, that we are actually able to begin to change the pipeline as well and have other trainees begin to take away this idealism and incorporate it in their own work and hopefully begin to build that capacity across the United States such that we will overcome this mess of a healthcare system we're in. And so now I'll take questions. I know that was kind of all over the place. This is our website and our, which we haven't updated in 2 years, so I apologize, but this is our team. It's called the Partnerships to Advance Cancer Care.
Thank you, Manali. That amazing set of research and work and really making a difference. I'm gonna go to Mohana's question, who has her hand raised.
Hey, Manali.
Hi, Mohana.
Sorry. Thank you so much. I feel like I've seen your work in like almost every presentation. And for others who don't know me, I'm an oncologist at the Cancer Center at Stanford. So I think I cite Manali's work all the time. I guess one question and struggle we've had is the idea of us as oncologists doing the work and talking to our patients versus documenting it and showing that like the clicks matter, and I'm a big proponent of that and get into trouble for it. So I'm curious, with all the decade of work that you've said, like how have you been able to kind of make that, I guess, justification for those extra types and clicks?
Yeah, I still struggle with that, to be honest with you, Mahana, because I don't do a great job of documenting. And I still have a really hard time of like, what is, at least at the VA, I know that the machine is not a billing machine, but rather, but it's hard too sometimes to like think about the notes as kind of a way to bill for additional services rather than the intended intent to kind of help the clinicians and also help the patients. But what I think was leading, it wasn't really us trying to pushing the clinicians. It was actually these discussions with the patients, because they would actually want a copy of the documentation. They would ask for it, and we would train them in our conversations, right? Of like, you should have access to all of your records. And when you go in, you should have a copy of, where you've discussed your goals and preferences, and be able to review it and make sure that the content is correct, because you may end up in the ER and that may not actually be reflective of what your interests were. And you should feel the desire and feel like you have the activation and encouragement, competence to be able to change that as well. And so I think it was actually led by the patients themselves, not by anything we did. We think it was mostly because the patients were asking for this to be in their chart and for other people to review. At the VA, we've got what's called the an LS, I think it's like the LST. So it's like the life-sustaining treatment documentation. And there was also a really nice clicky button where you would click on it, and it was very concise goals of care note. And the people that were reviewing it I didn't present this data, wasn't the oncologists, right, that were reviewing it. It was the ER physicians that was reviewing it the most. And the primary care physicians would go in and click on this goals of care documented note. I think they've now gone away with it because we have the LST, but it helped then when we had an in-service with the clinicians after this occurred, saying, look, it's really going to help so that you're not getting those phone calls at 3 a.m. saying your patient's in the ER. It will actually help to reduce things if you keep that document updated. But it's a good question. I would love to have, hear your thoughts about it. I know there's been a lot of efforts at Stanford as well. And we had Bismol, we did a project at Stanford with the serious illness conversation program with Ariana labs. And the rates of documentation, even when we had the navigator filling out half of it, were really horrible. I don't know if that's still the case.
Yeah, and I don't want to take up everybody else's time because I could probably talk about this for the next 2 hours, but I think it's getting better. I think it is a culture change, and at least for me, we both treat lung cancer, and so it's kind of interesting because even for me, when I know it's the right thing to do, a lot of times I'm like, I don't want to like write this in this other form. Like I just had a 40-minute conversation with my patient, so I think what I've been trying to work on is actually trying to make sure that we can see how many people click on it. And just honestly, just even start with like anecdotal evidence. We have hospitalists, for example, at Stanford who are not trained in oncology, but they are on our oncology services. So just starting with very basic, like not very scientific, but just kind of saying, do you look at this? And they do. And I think even broad categories of days to weeks versus months to years, which are still probably too broad from an oncology perspective, matters. I think your work, that's where it's just proof, because as you know, there is data out there for the fact that goals of care sometimes doesn't improve things like acute care use. And so there's always that kind of, person who's like, well, did you see this article? And it's like, yes, we're aware. But I think your work being so close to home is, I think, really an impetus. So we're working on that from our end, on like basically seeing that people are using that. We of course have that group of population. I have patients where I've had 5 of those goals of care conversations and they've still ended up in the ICU. So we're still gonna have that. But I think you're right. For most people, that's a really good call out, that maybe the impetus is patient facing almost more than, physician facing. So yeah, thanks so much for your work.
I think what's interesting too, I don't actually think that documentation leads to I mean, honestly, to be honest, I'm not sure that, I think for the ER and for other places, maybe the documentation helps, but it's that process. And it's also the fact that what I think was missing in the way that it was implemented at Stanford is that it shouldn't be this like one-time done, check mark, finished. It's actually, in what we built into these interventions is that it's over time, right? You've got to continue. If there's a trigger, such as an unexpected hospitalization, that's when that lay health worker is going to call the patient again and say, this is the time to rediscuss, right? Or you've got a side effect that you didn't experience. You need to give your clinician a timeout. We always say timeout. Like, you're going to give your clinician a timeout. You're going to say, hold up, wait a minute. I did not expect to have all this nausea and vomiting and then have to spend 5 hours of my life in the ER to get anti-nausea medications. And so that kind of building that in, that it needs to happen routinely at multiple points. And it will have to, unfortunately, be addressed by the patient, because even though I do this work, I don't always readdress it. And so sometimes, it's the hand on the door, bye, see you later. And the patient's like, no, wait, I'm confused. When we first met, you told me I had stage 4 cancer, and now I've been on immunotherapy for 2 years. And you're now saying my cancer's not seen on the scan. What does that mean? And I'm like, yeah, that's got to be really confusing for people. But
Yeah,
I don't.
we're building on that right now. So you've like kind of led the way. So thank you again for all your work.
Well, this is a great conversation, and I think if you have enough time to go till 1 Manali, that would be great.
Yeah.
But I want to release everyone who needs to get ready for their next meeting. But remember, submit your publications for the award and apply for Lily Donnelly Seed Grants. And anyone who has remaining questions can remain on the line. Thanks.
Hey, Manali and all. I'm Anna. I'm from Ambulatory Quality at Stanford. Thank you so much. This presentation has been amazing because I work on advanced care planning projects, primarily with primary care. So it's a little bit different. I think you focus more on oncology patients, but we started off with just very minimalistic documentation just to start breaching the topic with these patients. But now we're shifting more towards sick-P conversations. And all the hurdles that he talked about, we're definitely going through that. I think resourcing is an issue. Have you worked at all with primary care? Do you have any tips or
where it needs to happen? I'm like, I hate that. Right. And it's kind of like the driver's license, where when you go to get a driver's license, you are asked if you want to be an organ donor. And it's not like, none of us, I remember initially being like, whoa, wait a minute, that's kind of interesting. They're asking us to be an organ donor. Yes, that's right. Because if we die in a car accident, they need to know what to do with our organs. I always marvel at the fact that people show up in my clinic with cancer and have never had a goals of care conversation. And it's so much harder to start it then when there's a serious illness than to have started it without having all that stigma attached. Somehow these conversations are then linked to like death and dying, which it doesn't need to be. It's actually about values, preferences, goals. And it can be about what someone may want at the end of life, but doesn't always have to be. Primary care is where it should start. And it should be completely divorced from any sort of serious illness. It should just be a conversation of like, what are your goals and preferences if you were to get sicker? And it's not always linked with this current diagnosis that someone has. It's more like, we do this for everybody as part of your new patient packet. You're going to get this. In the same way, when you show up to the ER, you have to sign an advance directive, right? You've got to sign all this paperwork. Can we not standardize that as part of like Stanford's way? And that's what we've done in all these other projects is when you sign up for insurance, you get this new patient insurance packet. So with the labor union organization, you get a packet of information regardless of if you have any sort of illness. And in that information is an advance directive. There's information about goals of care, and it's just education. And then when you develop an illness, it will be easier because you've ridden the bike once, you know how to ride the bike. It's not so hard, and there's not so much stigma attached with it because all of that upfront work has been done. But for primary care clinicians, you all are so busy. I mean, you're forced to have to do X, Y, and Z performance metrics. It just shouldn't be reliant on clinicians to do this. It could be reliant on navigators, new patient coordinator. There are other ways to train people in the healthcare system to work to the top of their licensure to begin to educate people. And that's kind of the paradigm shift here. I'm happy to help you with anything, I'll give you my email address. I think it's probably in the, on the website maybe, but I will send it to you and answer and help with whatever we can.
That would be fantastic. Yeah, I think there's a lot from providers that are really dedicated and interested in this. It's a matter of resourcing because there's so much that you need to fit in primary care these days in 15 minutes. And patients don't come often either. So yeah.
And so you're going to do it in that first visit when you're meeting people. That just seems right. And then you're right. They don't come as often. And so things can happen in the middle. But that's why I don't think it needs to fall on the clinician. The clinician can address it after someone has already done that work of, I'm going for my mammogram today. I got this huge phone call of like screening. That person would have been the ideal person to say, hey, and by the way, we're going to mail you some packet of information. Can you just take a look at it? And here's a little bit about goals of care. It doesn't need to be a lengthy conversation. It can be 5 minutes, just an initial introduction.
Yeah. Thank you so much for that. I will send you an email and hopefully we can connect afterwards.
Of course. Thanks so much for being here.
It's great. Thank you, Manali, so much. Very interesting. And yes, ESU is working on with SICP team. So we also probably will email you questions. But
please, happy to help in any way. I think we can do such a better job of using it, all folks in our team, especially for our patient population here.
Yes.
Thanks again for the award. I'll let all the other team members know. They were so sad to have missed it. Everyone has clinic, but and they're all in Fullerton. So
oh yeah,
it'll be on the website soon, probably by next week.
Yeah.
Well, we'll let you know when it is. Selena, we'll send a special note to you, Manali, so you know. Thank you so much.
Thank you.
Thank you all.